عليكم ورحمة الله وبركاته. I'm Dr. Manal Hamza from Clinical Pharmacology Department. Today's lecture, inshallah, will be about anti-malarial drugs and treatment of malaria and prophylaxis against malaria. We start now with part 1 of the lecture, which is about pharmacology of anti-malarial drugs. Before discussing the anti-malarial drugs, we have to revise quickly the life cycle of the malaria parasite. The life cycle starts with injection of the sporozoites by mosquito into blood capillary. The sporozoites will migrate to the liver and develop into hepatic schizones. The hepatic schizones rupture to release merozoites. Merozoites will enter red blood cell to develop into blood schizont. The blood schizont will rupture, red blood cell rupture, and lead to acute attack of malaria, and then the merozoites will repeat the life cycle. One of the important characteristics of the life cycle of B. vivax and B. ovale species is presence of the hypomonozoid form of the parasite. Some of the sporozoites will enter the liver cell and go into dormant stage, which is called the hypomonozoid. The hypomonozoid will become dormant for maybe months or maybe years and may develop into schizones and can lead to relapse of malaria. This information about life cycle of the malaria parasite will help us to know the classification of anti-malarial drugs. Up to now, we don't have one drug which affects all stages of malaria parasite. So, drugs used for treatment of malaria, which are used for treatment of acute malaria attack, are divided into drugs which bring about clinical cure and drugs which bring about radical cure. Drugs which bring about clinical cure, these drugs act on the blood form of the parasites, will kill the parasite inside a red blood cell, and prevent rupture of red blood cells and cure attacks of malaria. This drug or this type of treatment is enough in the case of Plasmodium falciparum and Plasmodium malaria. However, in infection due to Plasmodium vivax and Plasmodium ovale, due to the presence of hypomonozoid form of the parasite, the drug used for clinical cure has to be accompanied or given with another drug which is active on the hypomonozoid form of the parasite to prevent relapse of the malaria. So, in the treatment of Plasmodium vivax and Plasmodium ovale malaria, we have to give one drug to bring about clinical cure and another drug to bring about radical cure by eradication of hypomonozoid form of the parasite in the liver. What about prophylaxis? Traveler to malaria's endemic area has to receive chemoprophylactic drug in order to prevent infection by malaria parasite during traveling. We have two types of chemoprophylaxis: primary chemoprophylaxis and terminal chemoprophylaxis. Drugs used for primary prophylaxis are blood schizonticidal agents. It means they act on the blood form of the parasite to prevent its development into schizones and prevent attacks of malaria. However, in the case of the traveler to an area endemic in B. vivax or B. ovale malaria, this primary prophylaxis has to be accompanied by another mode of prophylaxis, which is terminal prophylaxis. When the traveler coming home, he should receive a drug which eradicate hydrozoid form of B. vivax and B. ovale to prevent relapse of the malaria. Anti-malarial drugs include the following drugs: chloroquine, quinine, methylquine, proguanil, artemether-lumefantrine, brilaquine, tafloquine. Also, quinine can be used in combination with doxycycline or clindamycin. If you remember in infection 1 module, we study a group of antimicrobial called protein synthesis inhibitor. Among protein synthesis inhibitor, we have tetracyclines including doxycycline, and also we have clindamycin. This doxycycline and the clindamycin, they have antibacterial activity in addition to their anti-malarial effect. All anti-malarial drugs can be given orally, and they are well absorbed from gastrointestinal tract. In order to facilitate discussion of pharmacology of anti-malarial drugs, according to their clinical use, they are classified into 3 groups. The first group include, as you see, chloroquine, methylquine, and a combination of 2 drugs which are atovaquone proguanil. Atovaquone proguanil is a fixed combination of 2 drugs. Chloroquine, methylquine, atovaquone proguanil all have their anti-malarial effect on the blood form of the parasite. They are blood suicidal agents. So, what is their clinical use? They are used for clinical cure. Meaning, the patient present with acute attacks of the malaria, and after diagnosis is made, the treatment should be used immediately and include a drug which acts on the blood form of the parasite to kill the parasite inside red blood cells and cure attacks of malaria. So all the 3 are used for clinical cure. As I mentioned in the first slide or second slide in this lecture, if the infection is by B. vivax or B. ovale species, these drugs should be followed by other drugs to bring about radical cure. Also, the 3 drugs are used for primary prophylaxis. Primary prophylaxis given to traveler to malarious endemic area in order to kill the blood form of the parasite and prevent the infection of red blood cell or development of the parasite inside red blood cells, so prevent the attacks of the malaria. If the traveler is going to go to an area where B. vivax is endemic or B. ovale is endemic, this drug should be given with another drug which can bring about terminal prophylaxis after returning home. Now we will discuss the pharmacokinetic characteristic of chloroquine. Chloroquine is partially metabolized in the liver and partially excreted unchanged in the urine. A drug which depends partially on the renal elimination, the dose has to be adjusted in patients with renal impairment. The adjustment of the dose depends on the creatinine clearance. Chloroquine is concentrated in different body tissue, including liver cells, and then it is slowly released from this tissue in order to be eliminated. So chloroquine has a very long T-half which can extend up to 50 days. Chloroquine is a drug which is well tolerated, mild adverse effect like headache, dizziness, and abdominal pain. Chloroquine is a safe drug to be used during pregnancy for treatment of malaria. And also for primary prophylaxis. What about mefloquine? Mefloquine is metabolized in the liver, and it also has a long T-half of about 21 days. Mefloquine adverse effect including neuropsychiatric adverse effect. Neuropsychiatric, I mean it can produce seizures as a neural adverse effect, or psychiatric manifestation in the form of delusion, anxiety, depression, sleep disturbance. So the mefloquine should be used cautiously in patients with history of neuropsychiatric diseases like epilepsy and psychotic disorders. Also, the drug can produce sinus bradycardia, so it is better to be avoided in patients with cardiac conduction defect. The drug is safe in pregnancy. What about this fixed combination of advocone proguanil? Proguanil is eliminated partially by the kidney unchanged, while advocone is excreted unchanged in the bile. Because the elimination of proguanil depends on the renal function, this combination should not be used in patients with renal impairment in whom the creatinine clearance is less than 30 milliliter per minute. This drug can produce mouth ulcer due to proguanil part of this combination, and also the drug should not be used during pregnancy. We go to second group. The second group include quinine and artemethyl lumefantrine. These drugs are effective against blood form of the parasite, but they are only used for clinical cure for acute malarial illness. I should mention that when they are used for clinical cure of Plasmodium vivax or Plasmodium ovale malaria, they should be accompanied by another drug which is effective against the hypoluzoid form of this parasite in the liver to prevent relapse of malaria. Pharmacokinetic of quinine. Quinine is metabolized in the liver and it has a short T-half. It is given orally and well absorbed, as I mentioned before. However, in the case of severe malaria, it can be given intravenously. When it is given orally, it is combined with either doxycycline or clindamycin. The adverse effect of the quinine include synchronism and idiosyncrasy. What is synchronism? Synchronism is a group of symptoms which include tinnitus, mean noisy hearing, decreased auditory acuity, dizziness, headache, nausea, and vomiting. All these symptoms can be called synchronism. Also, idiosyncrasy. Idiosyncrasy means abnormal response to the drug due to genetic abnormality. Idiosyncratic reaction appear in the form either itchy skin rash, here we can call it urticaria, or only skin rash. The drug is safe during pregnancy. What about artemethyl lumefantrine? Artemethyl lumefantrine is a fixed combination of two drugs. Both drugs are metabolized in the liver to more active metabolite against malaria parasite. Adverse effects are uncommon and mild adverse effect. The drug cannot be used in the first trimester of pregnancy, but can be used in the second and third trimester of pregnancy. The last group include two drugs, primaquine and tafenoquine. These two drugs differ from previously mentioned drug by being active against hepatic form of the parasite, including the hyponozoid form of B. vivax and B. ovale infection. So, what is their clinical use? When I mentioned the previous drug, I said when they are used for clinical cure, they have to be accompanied by another drug which bring about radical cure. So, these are the drugs used for radical cure. So, primaquine, it is used for radical cure of B. vivax and B. ovale malaria. They don't cure the acute illness, so they must be accompanied by a drug which is a blood studenticidal agent. Primaquine also it is used for terminal prophylaxis. It means that a traveler coming from an area endemic in B. vivax and B. ovale, after returning home, he has to receive terminal prophylaxis in order to eliminate the hyponozoid form of this parasite to prevent the relapse of malaria. Moreover, primaquine now is used as primary prophylaxis. It is effective against hepatic form of the parasite, so it is used as a primary prophylaxis, and it is given before traveling to malaria's endemic area, during staying in the malaria's endemic area, and after returning home. And in this case, if they are used for primary prophylaxis, terminal prophylaxis is not needed. Primaquine is used as a primary prophylaxis against B. vivax malaria. Primaquine has a short T-half, only hours. And this can affect the frequency of administration of the drug when I compare this frequency of administration with frequency of administration of tafenoquine. Primaquine can lead to hemolytic anemia in patients with glucose 6-phosphate dehydrogenase deficiency, or in traveler with glucose 6-phosphate dehydrogenase deficiency when it is used for prophylaxis. So you cannot prescribe primaquine unless you are sure of glucose 6-phosphate dehydrogenase status of the patient or traveler. The drug is contraindicated in pregnancy. Why? Because the drug can cross placenta, reach the fetus in utero, and if this fetus is deficient in the enzyme glucose 6-phosphate dehydrogenase, the fetus may develop intrauterine hemolysis and it may lead to intrauterine fetal death. Tafenoquine is a more recent drug. It is drug first related to primaquine, but it is more recent drug. It is like primaquine, effective against hepatic form, but of all species of malaria parasite, including the hyponozoid form of B. vivax and B. ovale. It is used for radical cure and terminal prophylaxis. I repeat the same story. A patient present with acute malarial illness. You give blood schizontocidal agent like chloroquine, quinine, mefloquine, and the others drug which are mentioned, but which bring about clinical cure. But after clinical cure, in the case of B. vivax and B. ovale, I have to prescribe a drug to bring about radical cure, and the drug bring about radical cure like tafenoquine. What about terminal prophylaxis? The same. A traveler coming from an area endemic in B. vivax or B. ovale. During his traveling, he received a drug other than tafenoquine and the primaquine. So, once returning home, he has to receive tafenoquine in order to eradicate the hyponozoid form of B. vivax and B. ovale and prevent relapse of malaria. Now, tafenoquine also is used as primary prophylaxis for traveler to malarious endemic area against all species of malaria parasite. An important characteristic of tafenoquine which differentiates it from primaquine, it has a very long T-half. The T-half can extend up to 16 days. See, primaquine half-life is hours. This permits a single dose of tafenoquine for radical cure and for terminal prophylaxis. What about primaquine? Primaquine for radical cure, daily dose for 14 days. Single daily dose for 14 days. What about terminal prophylaxis? Also, the primaquine is given as a single dose for 14 days. So the long T-half of tafenoquine permit of a single dose for radical cure and for terminal prophylaxis. The administration of both drugs for primary prophylaxis will be discussed later when we discuss prophylaxis against malaria. Tafenoquine, like primaquine, can lead to hemolysis in patients with glucose 6-phosphate dehydrogenase deficiency. So cannot be used unless the status of the patient, of the traveler of glucose 6-phosphate dehydrogenase is identified. I mean, I have to test for this enzyme before prescribing tafenoquine. It is contraindicated in pregnancy because it can also cross the placenta, and if the fetus is in utero is deficient in glucose 6-phosphate dehydrogenase enzyme, it may lead to intrauterine fetal hemolysis. It is also contraindicated in women breastfeeds their infant if their infant is deficient in enzyme glucose 6-phosphate dehydrogenase, or the infant glucose 6-phosphate dehydrogenase status is unknown. The drug should not be increased in, should not be used in patients with psychotic disorder, because it can increase the severity of sleep disorders, of anxiety, of depression. So it is better to avoid in patients with psychotic disorder. Treatment of malaria. Treatment of malaria. How to treat acute malarial attack. Once the diagnosis of the malaria has been made, the use of anti-malaria drug should be used, should be started immediately. The treatment should be guided by the following 4 factors. The first factor is infecting Plasmodium species, whether it is P. falciparum, P. vivax, P. ovale, or P. malaria. Clinical status of the patient, whether it is uncomplicated malaria or severe malaria. Expected drug susceptibility of the infecting parasite. From where I get this information about susceptibility to anti-malarial drug? Respected health authority like Center of Disease Control of USA or WHO publish data about distribution of the malaria all over the world, about the prevalent species in each country, and also publish data about the pattern of resistance to different anti-malarial drug. So when you identify the species, you can, and you know the geographical area at which the infection is acquired, you can go to internet resources and revise the data about this particular geographical area where the infection is acquired. Also, we have to consider previous use of anti-malarial drugs, including those used for chemoprophylaxis. A traveler may develop chemoprophylactic failure due to different reasons and acquire malaria infection. So in this case, he has to receive another anti-malarial drugs for treatment, which differ from the drug used for chemoprophylaxis. We start with recommended treatment for uncomplicated malaria. The species of infecting parasite is identified. You diagnose your patient as uncomplicated malaria. You ask the patient about the geographical area where there is a high possibility of acquiring the infection. You go to the internet resources to check whether the malaria species in this geographical area is chloroquine sensitive or chloroquine resistant. If it is chloroquine sensitive malaria, the best drug is chloroquine or hydroxychloroquine, because this drug is safe and in this case it is also effective. But if you check your resources about the geographical area at which the patient acquires the infection, and you get the information that the species in this area are chloroquine resistant malaria parasite, whether it is chloroquine resistant B. falciparum, chloroquine resistant B. vivax, or any malarial species, malaria parasite species. For treatment, we have 4 options. The first 2 options are equal. You can use either of them. You can use either Advocone proguanil or artemisinin lumefantrine. The third option is quinine plus doxycycline or tetracycline, or quinine plus clindamycin. The last option, which is used when the other options cannot be used for a reason or another, is mefloquine. Why mefloquine is the last option? Because of the adverse effect of mefloquine. Mefloquine can lead, as we discussed before, neuropsychiatric adverse effect, neuropsychiatric adverse effect like seizures, like depression, like delusion, like anxiety. So while the other drugs are more safer. Also, mefloquine can lead to sinus bradycardia. So it is the last option. Look to the first 2 options, Advocone proguanil and artemisinin lumefantrine. Which one I can use? I can use either of them. But suppose that your patient has creatinine clearance less than 30 milliliter per minute. So here you cannot use Advocone proguanil, but you can use safely artemisinin lumefantrine. What about your option for treatment of malaria during pregnancy? For treatment of malaria during pregnancy, Advocone proguanil cannot be used. It's contraindicated in pregnancy. Artemisinin lumefantrine is only used in the 2nd and 3rd trimester. Quinine plus doxycycline is contraindicated in pregnancy. Why this is contraindicated in pregnancy? Because doxycycline can be deposited in the developing bone and teeth of the fetus, and it can lead to permanent staining of the teeth and delayed bone growth. So in pregnancy, you may use mefloquine very safely. Mefloquine can be used during pregnancy. If the infection is due to Plasmodium vivax or Plasmodium ovale, the drugs used for clinical cure, which I mentioned before, Advocone proguanil, artemisinin lumefantrine, quinine plus doxycycline or quinine plus clindamycin, mefloquine, all are blood suicidal agents. And if I want to eradicate the hyponozoid form of the B. vivax and the B. ovale malaria, I have to give a drug for radical cure. What are the drugs which are used for radical cure? Brimaquine and tafenoquine. Brimaquine for radical cure is given daily for 14 days. Tafenoquine for radical cure is used as a single dose because it has a very long T-half, and also you have to know that tafenoquine, it is not approved in children, cannot be used under the age of 16 years. And before you use brimaquine or tafenoquine, you have to test the patient for glucose 6-phosphate dehydrogenase status, whether the patient is deficient or not deficient. What is the recommended treatment for severe malaria? For treatment of severe malaria, we have two choices. We can use intravenous artesunate. Intravenous artesunate is a drug related to artemether, and it can be given intravenously. However, if the artesunate is not available, a very good alternative is quinine, which is also given intravenously. Once the patient condition improves, you can shift to full course of oral anti-malarial drugs, any of the option I said before with uncomplicated malaria. Drugs for malaria prophylaxis. Who need chemoprophylaxis against malaria? Traveler to malarious endemic area need chemoprophylaxis. Residents in the malarious endemic area, the chemoprophylaxis is not recommended. Maybe the non-pharmacological prophylaxis is required. So chemoprophylaxis is only for traveler to malarious endemic area. When to start chemoprophylaxis and when we end the chemoprophylaxis. Okay. We have to start chemoprophylaxis for some drugs 1 to 2 weeks before traveling, and for other drugs for 1 to 2 days before traveling. Chemoprophylaxis should be given during the period of traveling and staying in the malarious endemic area. And after returning home, the chemoprophylaxis should be continued to cover the last minute infection for a period range from 1 week up to 4 weeks. Here I am discussing primary prophylaxis. Why we have to start the primary chemoprophylaxis before traveling? Because to achieve effective drug concentration of the drug before reaching malarious endemic area. And the time to achieve this effective, the time required to achieve this effective concentration depends on the T-half of the drug. So, if the T-half of the drug is long, like the T-half of the chloroquine, which is 50 days, and for mefloquine, which is 21 days, here I start chemoprophylaxis from 1 to 2 weeks before traveling. Either 2 weeks before traveling or at least 1 week before traveling to achieve effective concentration before reaching the malarious endemic area. For drugs with short T-half like doxycycline, like advocone proguanil, the chemoprophylaxis starts 1 to 2 days before traveling because this time is quite enough to achieve effective concentration of the drug before reaching malarious endemic area. What is the frequency administration of these drugs? Also, the frequency of administration of these drugs depends on the T-half. A drug with a long T-half, it is given weekly, while a drug with short T-half is given daily. After returning home, the primary prophylaxis will continue from 1 to 4 weeks after returning to produce what is called to produce what is called post-exposure prophylaxis. To cover the last minute infection. So let us go for next slide. Before selecting a drug for chemoprophylaxis, we have to gather information which help us to select the most effective and suitable drug for primary prophylaxis for these traveler, for particular traveler. We have to gather information about the planning of the trip, whether it is planned trip, maybe a trip after 1 month, after 2 weeks, and so on, or unplanned emergency trip after few days. Tomorrow I will travel to malaria endemic area. Okay. How often to take the drug? I told you before, drugs for primary prophylaxis are given either weekly or daily. Some traveler prefer weekly dose and other traveler prefer daily dose. But usually the traveler in a long trip prefer weekly dose. How long to take the drug? I told you the period of post-exposure prophylaxis extend from 1 week up to 4 weeks. So, traveler for short trip, for example, 3, 4, 5, 6 a week trip, will not be very satisfied if they receive post-exposure prophylaxis for 1 month. Okay, so for short trip, the traveler prefer short post-exposure prophylaxis. Cost of the drug. Because the traveler has to purchase the whole amount of the drug needed during the period of his traveling before his trip, because he may reach the country there and cannot find the drug available. Destination. Okay. Destination is so important in order to select a drug for primary chemoprophylaxis. I will tell you the importance of destination in next slide. But now to finish this slide, we have also to ask about pre-existing health condition which may affect our choice of drug used for chemoprophylaxis. In this slide, we know how knowing the destination of the traveler is important. As you see in this slide, this is the address of Center of Disease Control of USA. This site shows the distribution of malaria infection all over the world by countries. The countries are categorized alphabetical from A to Z to show certain information about distribution of malaria all over the world. The first country in this list is Afghanistan. As you see, Afghanistan is endemic in malaria, and a species of malaria there is resistant to chloroquine, so chloroquine cannot be used for chemoprophylaxis. The most prevalent species there is B. vivax malaria, and also it gives you a recommendation for a chemoprophylactic agent which can be given to a traveler to Afghanistan. So you can use Advacon, Proguanil, doxycycline, mifloquine, or tafenoquine. If you check Egypt, Egypt is not endemic in malaria, so traveler coming to Egypt does not need chemoprophylaxis against malaria infection. This table is not present in your text. It will show you only the variation in the T-half of different anti-malarial drugs. We start with Advocone. A T-half is 2 to 3 days, and which is combined with Proguanil, and its T-half is only 1 day. A drug like chloroquine or mefloquine has T halves around a month. T half of chloroquine from 1 to 2 months, while that of mefloquine it is from 2 to 4 weeks. Doxycycline T half is from 15 to 24 hours. What about the T half of primaquine and tafenoquine? The T half of primaquine is short, only 4 to 7 hours, while that of tafenoquine is around from 14 to 28 days. The previous table should not be memorized, but it will be applied here in this table, which should be known by heart. This table shows you when to start the chemoprophylaxis before traveling, frequency of administration of a chemoprophylactic agent, and the duration of post-exposure prophylaxis. We start with chloroquine, which has a long T half. Chloroquine chemoprophylaxis should start 1 to 2 weeks before traveling to achieve effective concentration before reaching malaria's endemic area. The drug is given weekly because of long T half, and the duration of post-exposure prophylaxis, which is given to cover the last minute infection, is around 4 weeks. Mefloquine, long T half, so it is given 1 to 2 weeks before traveling, given weekly, and for 4 weeks for post-exposure prophylaxis. Doxycycline T half is short, so it is given 1 to 2 days before traveling, daily administration, and for 4 weeks after returning home for post-exposure prophylaxis. What about Advocon Proguanil? It is also given 1 to 2 days before traveling. It is given daily, like doxycycline. However, the duration of post-exposure prophylaxis is only for 7 days. When chloroquine, mefloquine, or doxycycline or Advocon Proguanil are used for primary chemoprophylaxis, and the traveler is coming from an area endemic in B. vivax or B. oval malaria, here the primary prophylaxis should be followed by terminal prophylaxis by either primaquine, which is given daily for 14 days, or a single dose of tafenoquine. Both primaquine and tafenoquine can be used for primary prophylaxis. And in this case, if the traveler coming from an area endemic in B. vivax or B. oval, no need to for terminal prophylaxis. For terminal prophylaxis, because they are effective against a hyponozoid form of B. vivax and B. oval. As you see in this table, primaquine is given 1 to 2 days before traveling because it has a short T half. It is given daily and only for 7 days for post-exposure prophylaxis. Tafenoquine has a long T half of 16 days. So to achieve effective concentration, I start with a loading dose. What is a loading dose? A dose larger than a maintenance dose, which is given daily for 3 days before traveling to rapidly achieve effective concentration before traveling to the malaria's endemic area. The drug is given weekly and as a single dose when returning home. We apply the all information we get from this lecture to this clinical scenario. Ahmed is an engineer. He comes to the outpatient clinic because he is traveling after 3 days to Ethiopia in WHO mission for a week. He asked about a drug to be taken to protect himself against malaria infection. what are the information which can be taken or collected from this scenario. First, it is unplanned trip. Secondly, it is short trip. It is to Ethiopia. His destination is Ethiopia. Cost, it is not a problem to Ahmed. And also, no health problem appear in the case scenario. I gather this information, I go to internet resources, CDC site, and I get this information. Ethiopia is endemic in malaria, and the species of malaria there is resistant to chloroquine. The most prevalent species are B. falciparum and B. vivax. The recommended chemoprophylactic agent are advocone proguanil, doxycycline, mefloquine, or tafenoquine. It is unplanned trip after 3 days, so I have to exclude mefloquine because it has to be given 1 to 2 weeks before traveling. I also exclude tafenoquine because the glucose 6-phosphate dehydrogenase status of Ahmed is unknown. There is no information in the history to know about his glucose 6-phosphate dehydrogenase status. We left with advocone proguanil or doxycycline. Both are given 1 to 2 days before traveling and are given daily. But advantage of advocone proguanil, it is given only for 7 days for post-exposure prophylaxis. And it is a short trip for a week. So Ahmed, sure, he will prefer short post-exposure prophylaxis for a week instead of taking 4 weeks of post-exposure prophylaxis if he used doxycycline. But you have to tell Ahmed that advocone proguanil is more expensive when compared to doxycycline. If you are given in the exam any clinical scenario, you can analyze the scenario as I discussed with you now. It is very, you have to use internet resource very effectively here when you start to study this lecture, and you can find very valuable information in the internet. At the end, thank you for listening to me. I hope that you enjoy my lecture. Inshallah, we will contact each other when the academic year starts, and you can ask me any question. Thank you.